Assalamu alaikum, everyone. My name is Dr. Salim Adami. I've been working in Shalamar Medical and Dental College for the last about 20 years as a consultant physician and pulmonologist. Today, I've been asked to present the view of pulmonologist as regards the role of interaction with thoracic surgeons. As you know, in the last so many years, the roles of pulmonologists have been changing in that they are becoming more and more interventionist as well. Previously, a long time ago, the chest tubes would be put in by the surgeons. Whenever the chest tube needed to be put in, we would ask the surgeons to come in and help us. But now this role has been taken up by the pulmonologist. Not that surgeons don't do it, but whenever a patient is with the pulmonologist needing chest tube, it would be done by us. Similarly, video thoracoscopy would previously be done mainly by the surgeons, but more and more pulmonologists are getting trained, and we are doing this procedure as well very commonly. So it's very important for us to realize where the limit is and when we should involve the surgeons to come in and help us out. We must remember that patient is of prime importance. He belongs to nobody. He belongs to all of us, and we all have to think what is best for the patient. So when we think the role of surgeons is there, we should not hesitate and not delay it. So let's see what my talk will be about today. It is identifying the indications of surgical referral, and this referral should be prompt, and it should be in close collaboration with the surgeons, because once the surgeons are through with their procedure, they will probably refer the patient back to us for further management. One case where, as pulmonologists, we sometimes see patients in our OPDs is a patient who comes in with chest pain or shortness of breath, and on history, they tell you that they've had a blunt trauma recently. They think that the pain or shortness of breath is probably not due to the trauma, and this is some pulmonological problem. So in that case, we have to be able to identify if there is a surgical problem, and if it is so, then we should be able to refer that patient. For example, you can see in this X-ray that there is a opacification of the left hemithorax, which is possibly due to the blood accumulating in the pleural cavity due to this blunt trauma. So this patient should not be dealt by a pulmonologist. They should refer this patient to the chest surgeon. They may have broken ribs, they may have flail chest, and they may need some sort of surgery to deal with it. How to identify that there is hemothorax? You can put in a simple needle in the intercostal area and try to draw fluid, and when you see that there is no fluid, rather there is blood, it is a definite indication that chest surgeon should be involved. The other place where we need a surgical referral, unfortunately for us, is that when we don't have the expertise to put in a chest drain. It rarely happens nowadays. All the pulmonologists are trained to put in chest drains, and for various indications like pneumothorax or malignant pleural effusions and some other indications, when you need to put in a chest drain, it is usually done by the pulmonologists themselves. But suppose that there is a possibility that a trained person is not available for some reason, or a patient comes and out of hours and help is not available, then do not hesitate to call your surgical colleagues to help you out in this condition. So next indication is when you have put in a chest tube for, say, pneumothorax, and this pneumothorax is not resolving even after putting in suction, and there is a persistent air leak and there's a suspicion of bronchopleural fistula, then do not hesitate to ask your surgical colleagues to help you out. Sometimes there is a trapped lung as well, which is not allowing the lung to expand even after putting the tube. So that's also an indication where you need to ask your surgical colleagues to help you out. Tuberculosis is one problem where sometimes you have to refer the patient to your surgical colleagues for lobectomy or maybe even pneumonectomy, especially in cases where there is multi-drug or extensive drug-resistant tuberculosis patients, and they've been on treatment for a sufficient period of time without radiological improvement. Also, if there is localized disease in tuberculosis, and you think that this area of the lung is destroyed and would probably cause another exacerbation or reactivation of tuberculosis. This area, if taken out surgically, could help prevent that. So that's another indication. Similarly, patients with tuberculosis and also in patients of aspergillomas who present to you with massive or recurrent hemoptysis, which does not respond to medical treatment, do not hesitate to call your surgical colleagues immediately. In patients of tuberculosis with damaged lungs, with a high risk of relapse, again consider a referral to thoracic surgeons. Some patients have complications and sequelae of tuberculosis, especially in patients with multi-drug resistant tuberculosis or extensive drug resistant tuberculosis, which includes pneumothorax, empyema, aspergilloma, tracheal or bronchial stenosis, and symptomatic post-tuberculous bronchiectasis. These are also the cases where surgical colleagues may help you out and improve the quality of life of your patient. Let's move to another field, that is lung cancer. Most of the lung cancers can be diagnosed by pulmonologists using bronchoscopes or videothoracoscopes, but sometimes surgical help may be needed to to help you in staging the disease. Sometimes thoracoscopy, if not available with you, can be done by your surgical colleagues, and that can help you diagnose lung cancer. Surgery is also the primary mode of treatment in stage 1 and 2 non-small cell lung cancer. And this is also an important component in multimodality treatment of stage 3A non-small cell lung cancer. So do not hesitate requesting help of your surgical colleagues. As regards role of surgery in chronic obstructive pulmonary disease, sometimes you have a large bulla which is impairing the breathing. If you look in this picture, you can see a large bulla in the left upper side, and if this bulla is removed, the underlying lung can expand and breathing can improve. So bullectomy is one thing where surgeons can help you out. Lung volume reduction surgery is being done less and less nowadays, but that is also one modality, although with limited usage, which can improve the quality of life of certain patients. How lung reduction volume surgery helps is that it takes out the hyperexpanded upper lobe, and once you take that out, the underlying lung, which has been compressed and relatively normal, it re-expands and it improves the lung and chest wall mechanics. Pleural decortication is another indication, and this is to be done in patients who have had empyemas and which are not resolving. And if it is not resolving, it's better to refer the patient to thoracic surgeon rather than wait and wait and wait, because if the pleural peel becomes thick, then it becomes even more difficult to respond to surgery as well. If there is radiological evidence of a trapped lung, it is pulmonologist's responsibility to refer the patient timely, and as I've written, well before the 3 months for better outcomes. So now we can see that there are places, there are situations where the pulmonologists must and have to refer the patient to the chest surgeons, and that is all in the best interest of the patient. So in the end, I would say that pulmonologists and chest surgeons, they have to work in close collaboration. And if, as a pulmonologist, we feel that there is a need for the chest surgeons to come in, then we should not delay it, and we should refer the patient as soon as possible, and not just refer, but also communicate with the surgeons, tell them why you are referring this patient and what sort of help you need, be in close contact with them, collaborate in treatment. For example, if there are other conditions that have to be treated by you. For example, you're referring the patient for surgery due to tuberculosis. The medical management of tuberculosis still lies with the pulmonologist, and we have to continue doing that. We have to keep coordinating with the chest surgeons so that the end result is a patient who has healed and who is now healthy. The cooperation between the two sides, physician and pulmonologist, is of utmost importance for the betterment of the patient. So remember the 4 C's: communication, collaboration, coordination, and cooperation. I don't think I can add a lot more than this from my side, but I must re-emphasize that without the availability of help of chest surgeons, we cannot heal many of our patients. And likewise, the chest surgeons need the help of pulmonologists for the better management or post-op management of the patients. Thank you very much for listening to my talk. I apologize for not being very coherent some of the times. It's because we are all learning in this era of COVID to give our presentations to a computer. I can't see any audience. I'm just imagining that there are people who would be listening to my presentation. It's not the same as standing in front of you all and giving my presentation and interacting with you. So apologies once again. Hope you have a good time and hope you enjoy the coming presentations. Thank you very much. Take care.